Hi, welcome to another episode of Healthcare Simplified with Manvir Victor. And in this episode, we're going to talk about GPs. We're going to talk about the Malaysian Medical Association, especially because I've got the president, the newly elected president of the Malaysian Medical Association, someone who I've known for the past few years, and he's finally taken the helm of this organization for the next 1 year. Find out what his aspirations are, where is this going to move, and obviously the latest budget that has come out for our healthcare and has moved the goalposts slightly. Has it moved it better? Has it improved it for the doctors? I am very pleased and thank you so much for finally saying yes to come on our show. I have with us the brand new president of the Malaysian Medical Association, Dato Dr Thirunavukarasu Rajoo. Did I get that right?
Yes, correct.
Well, Dr. Arasu, I've known you as Dr. Arasu. Well, congratulations on becoming the new president of MMA. And before we go into your aspirations, but tell us a little bit about yourself. You know, you're a small kampung boy. Where are you from?
Thanks, Manvir. First of all, please allow me to thank you for giving me this opportunity. But nowadays we see that podcast plays an important role because it has a wider outreach.
Yeah.
Okay. Basically, like what you say, I'm a kampung boy. Actually, I was born in Hospital Bukit Mertajam, Penang.
Okay.
And then I grew in a small town called Padang Serai.
Right.
And throughout my primary school and secondary school was in Kulim.
Right.
Two schools, Sekolah Tunku Malik, primary school, and Sultan Badlisha.
Okay.
The premier schools in Kedah.
Right.
So I did that until Form 6. So before I pursued my studies to Indonesia.
Okay.
Interestingly, I went to an unrecognized university.
Okay.
So I came back and had to sit for the exam. In those days were 3 universities, either UKM, USM or University Malaya.
Right.
So I sat for the exam in University Malaya, and those days we had to sit for the final exam.
Okay.
So I passed the exam in University Malaya, final exam. Before I pursued my career, housemanship in University Malaya.
Okay.
And then later I pursued my MO-ship in Hospital Ampang, emergency department for 2 years.
Right.
Before I ventured into private practice.
When you were in Kedah and in Kulim, were you ever planning to be a doctor? Is your family doctors or?
I come from a very humble family.
Okay.
My father, he was a Tamil school teacher.
Okay.
My mother was a housewife.
Right.
And then none of the family members are doctors.
Right.
But of course, I always have this passion to be a doctor. But of course, when I was growing up, so I knew that one of the way to come out from poverty is education.
Right.
And for Indians, especially, is either lawyers, doctors, or engineers.
Right.
Those days.
Yeah.
So of course, that actually motivated me. But along the way, I developed this passion to be. I like to talk to people.
Right.
I like people. So that actually is a passion for me. Until now, I still practice.
Sure.
I still practice, and then even though I do management role, I still practice, and that is the most enjoyable part of my life.
Okay. Wow, this is fantastic. So all the way, did you ever at any point work in Kedah, Kulim, that area at all?
That's interesting.
Yeah.
I've never served my home state.
Really?
Yeah. After I left, I came back, I was in University Hospital, and after that was Ampang Hospital.
Right.
So I've been in Klang Valley for the last almost 30 years.
30 years. Wow. Okay. So now, tell us about, after working in the government and all that, you decided to go out and be a GP. What prompted that first?
That's very interesting. So because of why I decided to go into GP, because I also liked primary care.
Okay.
So GP is basically a jack of all trade,
okay,
master of none.
Yeah.
So you have this opportunity to meet the various walks of life, and also you're your own boss.
Okay.
Okay, so you can make decisions, right?
Yeah.
So that gave me a thing like, hey, it's good that you are on your own boss, and then you can also close to the patient, and then you do not see just one particular specialty, but you see a variety.
Right.
So that actually prompted me during my emergency time. I said, why don't I do this? That's how I went into a GP practice.
At that time when you did it, was it a huge risk? I mean, what was it like?
See, that time, I would say it was still okay.
Okay.
It was still okay. Way back in 2009, 2010, it was still very okay. Because why? the healthcare, the number of clinics was not that many.
Right.
And we didn't have this, what we call lambakan doctor at that time.
Okay.
So fairly system was a bit okay.
Okay.
It was still okay. Probably it was beginning to show.
Okay.
But then we entered, it was okay.
Okay.
It only got worsened from what I say from experience, probably after 7 to 8 years post Act 586 was
Yes.
gazetted. That's
Okay.
2006, right? So we started seeing the system from 2013, 14, 15. It started to go into a bit more tighter direction.
Okay, which is what we're going through today. Now, Malaysia is probably one of the best countries in the world for access to health. What I mean by this is 95% of the population is within 5 kilometers of a primary care. Now, primary care is defined as, your clinic kesihatan, your GPs. So, in the middle of the night, you need help, you can go somewhere. So Malaysia is great for that. I've grown up, I used to grow up in Seremban, wherever it was, there's a GP somewhere, Now, and when you say Act 586 has caused sudden these issues that happened a bit later, can you just delve into what is 586 and where do you think the effects came from?
You see, Act 586 is basically a Private Healthcare Facilities and Services Act,
Okay,
1998.
right.
So the bill was passed in 1998 and the regulation it gazetted in 2006.
Okay,
Of course, they have good intention. Just like any other act, you always have good intention.
yeah.
But sometimes you do not see the unintended consequences.
Okay,
Okay, sometimes the ministry wants to regulate the profession so much,
all right.
you actually strangle them.
Okay,
And every act you're supposed to review from time to time.
okay.
I think it has been stuck for a long time,
19 years.
19 years. So much so, any reviews, especially on the regulation, it was keep on tightening the noose.
Okay,
Okay, it was keep on tightening the noose. It was
Right.
not relaxing.
yeah.
It was like micromanaging the private sector
Okay,
to the core.
okay,
Okay, like for example, you have the door size. Of course, we understand the rationale for the door sizes in case of
the
emergency.
door sizes.
Door sizes, 1.2 meters, right?
Yeah,
We understand. In case of emergency, you want to evacuate the patient.
Yeah.
Smooth. But I visited many of these developed countries.
right.
Okay, in Japan, even in Australia, I visited. They focus on the patient outcome.
Okay,
Okay, here we are focusing on the door sizes.
okay,
Okay, and then the toilets. So because of that, because of all this compliance, the cost of doing business has gone up.
okay.
Because why? In 2006, probably the people used to build shop lots by 20 by 70 or 22 by 70.
Okay,
But today, it's getting smaller in size.
okay,
But for you to comply to the regulation,
right,
it's almost very difficult. It's not very economical.
right.
And on top of that, sometimes the enforcers also, they may, you see, in any sector, right, you'll have 3-5% who are outliers.
Right.
So when you want to address the 3 to 5%, the remaining 95% of us become victims. One classic example I can give you.
Yeah,
There was a circular from the Ministry of Health that says that the GPs cannot give IV drip in the clinic.
okay,
You can only give IV drip in the case of emergency, and then you must refer to hospital.
right.
You just rightfully said you're the neighborhood clinic,
Yeah.
you are the primary care,
Yeah,
a doctor that I can go and visit. Our
Right.
access is very high
Yeah.
globally, right? If basic things like, for example, a person coming with very bad diarrhea,
right,
they just need some hydration and go back.
right.
A lady who's having what we call as hyperemesis gravidarum, that means is the first 3 months you just keep on vomiting.
Right,
Okay, they just want hydration.
right,
A dengue patient, a very simple dengue fever that needs simple hydration and
Right.
proper monitoring.
Yeah.
So now, because of this, what we have to do, we have to refer to the hospital.
So,
So, but basically, what is happening is that why is the government? You see, basically, is it they don't trust us?
right,
Okay, if they don't trust us, if they feel the GPs are incompetent, but remember this: we were trained by the Ministry of Health.
yes, yes,
2 years of housemanship,
right.
2 years of MO.
Yeah,
Then you have released us.
yeah,
If you think we're not incompetent, if you think you're incompetent, why did you release us?
Right.
Right?
Right.
So these are sometimes this could be administrative, it could be
Right.
just one isolated cases.
yeah,
And then when you impose on everybody, right, you actually restrict the
Sure.
primary care in Malaysia.
right. Exactly. I mean, it's also one of my pet peeves when I look at laws, especially when it comes to healthcare law, because as a patient advocate, and you were just mentioning 2006 was when it was gazetted, but the law came from 1998, just 7 years before that, right? 7, 8 years before that. So you're talking a law that was literally 25, 27 years old
Yes.
is defining the door sizes instead of outcomes. And in today's world, if you had a 27-year-old car, it's classic. So basically, we have a law that's classic, and that's you're looking at that. That's the year it was decided and signed into law. There's obviously calculations, all these things that happened 2-3 years before that. This is a law, right? So a lot of groundwork goes into that. So we're talking about 30 years old, right? And it's archaic. To me, it's archaic that 30 years old, a decision is now defining how we get healthcare. And so has been obviously a huge hurdle for a lot of GPs, right? And there are 11,000 of them plus here in Malaysia today. How is the business faring for them?
You see, like what you rightfully said, Manvir, you see, the law is archaic. Because in 2015, I remember the government came out with good regulatory practice.
Okay.
Okay, good regulatory practice whereby every law, every act, you must review from time to time. But
What is that time to time?
that is the problem. The same thing like how you got stuck in our fee.
Right.
The time to time, there's no definition of time to time. So when there's no definition of time to time, so now there's no priority.
Yeah.
Right? So
Yeah.
that's why we got stuck there. So coming back to that, so in 2018, MMA did a study.
Right.
So we got 1,800 GPs who participated in this nationwide study.
Okay.
And it was published in a journal.
Right.
So from there, what we noticed is that almost 30% of the GPs who participated,
Right.
based on the cost metrics and their business on their practice.
Right.
So what we realized, they are not making money.
They're not making money.
Not making
So out of 11,000, you're talking about.
No, 11,000 is now.
Okay.
When we did the survey in 2018,
Right.
that time if we had around 7,000.
7,000. So you're talking about 2,000 plus.
Yes, 2,000 plus.
Oh.
Okay. So when I say, see, people might be wondering, what do you mean with not making money? They're still there. See, when we say the GPs, they're clinicians.
Okay.
They went into practice.
Yeah.
Of course, when go into practice is also part of the business. Why I say part of the business is self-funding.
Right.
The money you generate is to continue to sustain your practice.
Right.
And also to pay yourself.
Okay.
And many of these doctors, they do not take a salary.
Yeah.
They feel like whatever money that's left after that is what their salary, which is very wrong.
Okay.
Because why? If you're running a clinic from, let's say, for example, if you're running most of the clinics, almost 50% of the clinics are actually basically 16 hours, 14 hours clinic.
Okay.
Okay. Basically, if you work 14 hours a day, 1 week, you're talking about at least 14 times 7 is talking about 98 hours.
Right. That's a lot.
A lot, right? So after you work all the 98 hours, you have remaining of 10,000 ringgit, let's say, for example.
Right.
They think that is their income.
Hmm.
You see, by right, you should pay for yourself first. Okay, your 45 hours, how much is your salary? Let's say you pay, maybe that time was 8,000, 9,000.
Yeah.
You pay your salary first. Then your remaining 45 hours, let's say you pay locum. So you have to minus all those things.
Yeah.
Then only whatever is your profit.
Right.
But most of them, they don't do that. Then you have another 30%.
Right.
They're breaking even.
So you got 30% losing money.
Losing money. 30% breaking even.
Oh, that's
That
like
means
60%.
60%. That was in 2018. Huh?
Yeah.
So you have another 30%, I would say the middle class. That means they're okay, they're comfortable.
Yeah.
They're quite comfortable. Only less than 10% are doing very, very well.
Okay.
But the perception of the public is that, GP is more kaya. Why? Because why? Even you're now 50 plus, right?
Yeah.
Sorry to tell your age.
No, I'm
50
fine.
plus. Okay, so basically what happened is that those who are 50 years old, 60 years, 70 years old, they grew up in the era of probably in the 1970s, 80s, 90s, early 2000s.
Yeah.
Of course, the GPs are doing fairly very well.
Right.
So that is the perception that when they grew up, right? So now they feel like the perception when they grew up, the GPs are doing very well.
Okay.
So they'll feel the GPs are doing very well.
Right.
So that is the perception. But in reality, many of them are struggling. Many of them are struggling, and then many of them have shut down and gone to other things.
Right.
So for me, this is actually a waste of talent.
Waste of talent. Okay.
Because why? To train a doctor.
Yes.
See, a doctor, you asked me earlier, right? When you're 18, 19 years old, you go to medical school. Then 5 to 6 years.
Yeah.
Then you do your houseman MO.
Right.
So at least your prime time,
Yeah.
your prime time of in the 20s, you have the best energy 20s and 30s, right?
Right.
If you want to do specialization, you continue further.
Right.
That means 20 to almost close to 40 years old,
Yeah.
you are fully dedicated to do what you want to do.
Right.
right? You sacrifice your family, you sacrifice your so many things you sacrifice,
Right.
right? So then finally, what happened to them now? So for me, it's a talent.
Right.
You see, any developed country, they are hungry for talent. Are we hungry for talent?
Mm.
So that is the question the policy makers must think.
Okay.
Our member of parliaments and the parliament should be debating about that.
Yeah. And it's very important that you brought it up. You did this survey in 2018, and from that survey, 60% surviving or
Yes.
bad. So that's 60. And then you got 30% that are doing fairly well, and then there's 10%. That's 2018. Now let's fast forward to today, 2025. Now you're president of MMA. How much of that 2018 survey that you think is applicable today?
I would say it's still applicable. Maybe the situation would have got worsened. Remember, I was telling about
Worse.
Yes.
They get better.
Because why? There were close to a few thousand new clinics who opened up in the last post-COVID. Okay. Because why? Contract system
Yes. Yeah.
came in 2016.
Yeah.
So the MMA at that time warned the government. 2014, 15, we warned the government, hey, you're going to come out with this policy. The impact is going to be in 5 years' time when the cohort finishes. Please make sure there are safety nets for this. Because
Right.
there's a clear direction for that.
Yeah.
They never listened to us in 2014, 15. Repeatedly.
Right.
Okay, repeatedly. Then, of course, government changed in 2018.
Yes.
Then COVID came in.
Right.
Right? So the direction, focus all were towards managing pandemic.
Right.
Right? So the first cohort finished 2020.
Right.
But then because of pandemic, they all extended.
Okay.
So what happened after 2021? 22.
Right.
So they were all demotivated because the contract system was not very clear.
Right.
So, and then they were all burnt out because of the COVID. So many
Right.
things, right? So many of them also left. They saw there's no direction. They see that there's no future.
Right.
I'm a contract doctor.
Yeah.
I'm a contract person.
And
So
at
you get
that
a
point, they're
workload.
probably 32, 33 years old.
Yes. So they have the energy.
Yeah.
Right? They have the energy. So
Yeah.
they thought, why
And
should I just leave and then do something else? Thinking that the private sector at that time, they can do very well. So of
Okay.
course, many of them came into the private sector.
Okay.
Okay. And please bear in mind, many of them were trained only in COVID.
Yes.
You cannot blame them. So I would blame the system.
Right.
The system, the failed policy of 2015.
Okay.
They have intention why they were doing that. Fine, we agree.
Right.
It's supposed to be a short-term measure.
Right.
But whenever you do a short-term measure, you must have your short-term plan, you must have a mid-term, and also long-term plan.
Right.
So obviously, it shows that there was no clear plan at that point of time.
Okay.
Okay, today what happened? We were all firefighting. Every president will come pushing, no, we must abolish the contract system, right?
Yeah.
Finally, now this year, the Prime Minister has announced 4,500 plus of permanent posts, right?
Yes.
But what MMA is looking for, abolish the entire contract system and give permanent posts.
Yes.
This is what we're looking at.
Absolutely. So now that you are president, what would you feel is your role for this next year? What do you want to achieve?
See, for me, right, so one of the important things is leadership in healthcare by doctors.
Okay.
Not in isolation, but in collaboration.
What
So-
do you mean by that?
So why I say so, see the doctors, many of us, all of us are trained to certain leadership level, whereby we are trained to treat individuals. In that process,
Okay.
you develop leadership skills.
Okay.
Okay, but maybe we were not trained into finance
Yes.
and
Yes.
people management, so on and so forth. But nowadays, even in some of the medical school, they already start teaching them even entrepreneurship about doctors. So we feel you have an important asset.
Okay.
And doctors are the closest to the patient.
Yes.
Okay, because you're closest to the patient, you have this advantage to understand the pain point. Okay, so what we are telling the government is that take advantage of that. Take advantage of the skill set of doctors.
Right.
Okay, and how can you train them to play a more important management role? Of course, now we are having the Pengaras who are medical doctors,
Right.
and then the DG, of course, the head of medical services, right? So
Yeah.
I think they can play more important role.
Okay.
A more important role. For me, at the end of the day, you have a talent.
Okay.
How can we sharpen or upskill this talent
Okay.
to play the role of leadership? See, in any organization, leadership plays an important role.
Sure.
Like, for example, if you look at the healthcare in Malaysia, right? Ministry of Health is bloated.
Right.
You are the provider, you are the payer, you are the regulator,
Okay.
right? And then everything is centralized. Healthcare, you have to decentralize. It's central policy, but local implementation. You have to empower them.
Okay.
Do we know what are the issues that having, let's say, for example, Hospital Slim, I'm just giving an example.
Right. Right.
Hospital Slim River. The issues faced by Hospital Slim River
Yeah.
could be totally different from a hospital that is being faced probably in Seremban
Yes.
or in my hometown in near Kulim.
Right.
or in Sabah Sarawak. It's
Right.
all different. So
Right.
you have a lot of local issues,
Okay.
local demographic,
Right.
local demography in terms of socio-economy,
Right.
background.
Yeah.
So so you have to decentralize.
Sure.
You should empower them more,
Right.
so that this need to be not only spoken, it must be done.
Right. And so this is very interesting that you brought that up, because you have the Malaysian Medical Association, MMA, you're president of. Now, that is the umbrella organization for the whole of Malaysia. And you do have chapters in every state. Do you decentralize it to the state so that the state is able to understand, for instance, the Kedah, in Kedah, your home state? So the MMA Kedah president there is able to manage that situation according to what they need?
Yeah, so basically, of course, when we look at MMA also, of course, we have president, and then every state we have the branches.
You're right.
Okay, of course, the branches, they have their own autonomy to certain level.
Okay.
Okay, and they also, one of the tasks for them also to get close to the each state department, health department,
Okay.
all the Jabatan Kesihatan Negeri, so that they understand the local issues.
Yeah.
So sometimes in our WhatsApp group, the council members, we call it.
Right.
So sometimes they'll tell, okay, what are the issues they're facing in this hospital, that hospital, different states.
Okay.
Sometimes you can also see the arguments from them. From our colleagues in East Malaysia will not agree with our colleagues in northern side, and our colleagues in northern side will not agree with our colleagues in KL. So from that conversation itself, so
Right.
I knew the issues are very localized.
Okay, so now you are able to see that because you've connected it,
Yes.
but you've decentralized it. You know, everyone's connected and they can have those conversations. Does that happen in Ministry of Health at that level?
No,
Do you think?
No, I think it's happening because they do have regular meetings. They
Right.
have the DGs will always have all the DGs will always have the regular meetings with the HODs
Yeah.
and also the state health directors.
Right.
So meetings all happening. I wouldn't say they're not doing it. Yes, but now how do they decentralize?
Okay.
Of course, when you want to decentralize, a lot of things must be done.
Right.
Has the government thought about it? Yes.
Okay.
When they thought about it in the last couple of years, in 2023, the health white paper was passed.
Okay.
Okay, in the health white paper, there were 4 pillars, right? They talk
Okay.
about health reform, they talk about finance, they talk about health reform, finance, and and governance structure,
Yeah.
and so on and so forth. I mean, they've already spoken about all these things.
Right.
So now the question is that how from this document we can see even the Rancangan Malaysia ke-13
Yeah.
and this budget 2026
Yes.
is also part of the reform of the health white paper.
Okay.
So there must be more political power and political push.
Right.
Okay, that's why I always tell the member of parliament, this is what they should be debating in the parliament,
Okay.
because we are the taxpayers.
Yes.
They should be talking about this regularly more and more, because it affects everyone, whether you're rich, you're poor,
Okay.
whatever race or religion, everybody is affected by health.
Okay.
Sometimes it's not in your control, it's also.
Absolutely. Yeah.
Right? Even though you try to do whatever you want, accidents, for example, road vehicle accidents, it's not you in control.
Yeah.
Okay, so that is why this must be communicated, and the communication must happen more frequently.
So, I mean, your experience, you've traveled the world. I mean, as president, now you have a huge role for your GPs here in Malaysia. Would you say that there are some countries that we can learn things from? You know, we can pull one strand, are there neighboring countries that we can say, that's a really good idea. We should try to emulate something along those lines to improve primary care in this country. Any thoughts on that?
You see, to be fair to our healthcare system, right? Of course, I've traveled quite a bit overseas as well. I would say we are still one of the best system.
Okay.
Okay, for the little money that we're spending compared to many other countries, we are fairly doing good. But of course, we can see the system is cracking.
Okay.
So why is cracking? Our model that was developed was to manage those days maternal mortality, infant mortality.
Right.
We're talking about the 60s, 70s. The issues were different.
Yes.
We managed it very well.
Yeah.
But the issues we are facing for the last 20 years and moving forward,
Right.
about NCD, non-communicable disease, diabetic, hypertension, cholesterol, internet is coming, social media is coming. We can see how kind of scary things happening nowadays, right? Because of social media, gaming, so many new issues are coming up.
Right.
Then we are going to become age society, right? So definitely your health needs and the issues you're going to face will be different.
Right.
So are we ready to manage that?
Okay.
Then coming back to your question on primary care, yes, countries like, for example, in Australia,
Yeah.
they have a very good system whereby the GPs and the hospitals are all connected.
Okay.
Can we do in Malaysia? Yes, we can do. See, funding we should not put funding as the most important thing in anything. If you put the fund first, everything, you can't do anything. What about those low-hanging one? For example, this was one of the proposals by MMA to the government during the budget meeting.
Okay.
Is to develop clusters.
Okay.
Cluster. That means you have the GP clinics.
Right.
You cluster it together with the clinic kesihatan.
Right.
And then you cluster with the hospital.
Okay.
Primary care.
Right.
Private primary care. You have public primary care.
Right.
Because even in clinic, is there something they have specialty also?
Yes. Yes.
Okay.
They do.
And then you have secondary,
Right.
tertiary care, right?
Yeah.
So you map all these things. See what is happening in the country now. One area, what we call as wastages in healthcare.
Huge.
Huge wastages in healthcare. Repetition of blood tests.
Yes.
And then patients keep hopping from one place to another.
Right.
They know the clinic kesihatan is RM1.
Yeah.
They don't value the RM1.
Yep.
Most of them don't value the RM1.
Yeah.
That's why recently now in a budget proposal we said the government should increase to RM5 for clinic kesihatan and RM25 for specialists.
Yes.
But of course we want a safety net for OKUs,
Yeah.
a safety net for the B40 group, because in some places the parking is more expensive than RM5.
No, it is. I
Isn't
go to HKL, the parking is more than that.
So it doesn't make sense to
Yeah.
me that why can't we afford to pay this?
Yeah.
And then the statistics also shows by Qualico PC in 2015 by KKM and also UKM, a Malaysian visits an outpatient clinic, whether public or private,
Right.
3.9 times in a year.
3.9 times a
In a
year.
year.
Okay.
So we know that you go only 4 times in a year.
Yeah.
Of course, unless your family members is different, right? So looking into all these things, we must also educate the public
Right.
that healthcare is not cheap.
Yes.
So healthcare is a whole of society. It's a
Yeah.
whole of a nation.
Right.
It's every individual's responsibility.
Absolutely.
The government's job is that to ensure they put a proper policy in place.
Yes.
That's their job.
Yeah.
And make sure how you're going to talk about funding, how you're going to manage the workforce.
Right.
Okay, funding, workforce, reforms,
Yeah.
like governance. That's what their job is.
Yeah.
You see,
Absolutely.
so definitely we can learn.
Yeah.
Even from Singapore, of course, people say it's a city-run state. Fine.
Yeah.
If you want to learn, even if you learn from Africa, you can learn.
Yeah.
So you can learn from Australia what they've done. So what I told earlier was the cluster.
Yeah.
So when you develop a cluster, that means let's say a GP now refer to a clinic kesihatan
Okay.
or GP refer to a government hospital.
Yeah.
There must be continuity of care.
Sure.
Okay, at least the GP will know what has happened to the hospital. And also must have a system whereby there's a friendliness between public and private.
Okay.
After all, we are all from the same system, right?
Yeah.
Okay, so there must be friendliness. Of course, we know the public sector, they're overwhelmed. We agree.
Right.
We understand. We also from there.
Right. Yeah.
Okay, we must find mechanisms.
Yeah.
Like, for example, they have done in one of the hospitals in Ishtar, whereby the emergency department,
Yeah.
they showed it at Tajuddin, I think. So they have developed a WhatsApp group, simple WhatsApp group,
Yes.
among all the GPs around there. So
Okay.
for communication.
Right.
See, one of the most important thing in healthcare is communication.
Yep.
Right?
Yeah.
Like, for example, now for the last 2-3 weeks, you can see an outbreak of influenza cases, right?
Yeah.
Influenza cases. So
Yeah.
how well is public and private communicating? Is there a communications taking place or not? So these are the simple things actually we can do,
Right.
which doesn't involve cost.
Okay.
It just involves leadership.
Yes.
That's why I was telling earlier, leadership.
Yes.
It involves local leadership,
Right.
local empowerment,
Right.
and communication.
Okay.
So when we do that, then the public will know, hey, even if I do private hospitals, and these clinics are also connected to the government, they know when to refer, what to refer.
Yeah.
But sometimes you must always remember this. You're a patient.
Yeah.
When you're a patient, at that point of time, what do you want? You want somebody to guide you,
Yeah.
somebody to reassure you.
Yes.
As simple as that.
Right.
Not to solve your problem on the spot.
Yeah.
Not all the problems we can solve, but at least I can guide the patient
Yeah.
to do this. Like, for example, I tell you a case that we see in the clinics, right? Contrary to people's belief, we do see quite sizable B40 population.
Okay.
Okay, when they come to the clinic, private patients, they do come. When they come to the clinic, right, sometimes we know they're having this condition and it's not an acute condition, but we know if you do not take care, it'll become acute in the future.
Right.
But they can wait. Maybe they can wait 3 months, 4 months, right? So sometimes we ask them. And we know at the GP also, we cannot treat beyond that. We have to refer them. Sometimes we tell them, hey, why don't I give you a letter? You go to the private hospitals. Probably you can do a scan or do this. Okay, you come back with the report so that it may cost you in the private hospitals maybe 500, 600, whatever for that particular investigation. And then I can refer you to the hospital, government hospital, so that you'll be fast-tracked. Because why? Otherwise, we refer to government hospital, the system is congested.
Right.
The waiting time is very long. So by you spending this extra money,
Yeah.
at least your trip will be faster. See, these are all a very valuable information.
Absolutely, yes.
Valuable information.
yes,
That's
yes.
what most of us GPs we do to our patients.
Right.
We guide them.
Yeah.
So at that particular point of time, what a patient needs is guidance and reassurance.
Yes.
That's all they need to know. They ask doctor, mana mau pergi? Which pakar I want to see? So this kind of, then they'll be thinking, it's okay. I think 500, 600 ringgit, I think I can do it. If my time can be shortened to see a pakar. Because we also help the government, right? Otherwise, look at the process. I refer you. Somebody at the counter will see, okay, this is not very emergency. Okay, I'll give you 3 months or 4 months. Then 3 months, 4 months, you go and see a specialist or pakar MO there. They say, okay, you must go do investigation. Then you go for investigation. Then you got a waiting list for that. Then after that, you come set. So these are all waiting time goes up.
Right.
Goes up. So now with 500 or 600 ringgit, I'll cut all these things. The doctor also can make a decision. So what we are telling, this is what the GPs are doing. So if you can leverage on this, a communication. Okay, for example, if a GP communicates with the clinic directly to get a appointment, they can fast track it. Because you're colleague to colleague speaking one.
Sure.
So this, what is the cost to the government?
Nothing.
This is why I say leadership comes in. Local leadership comes in.
And
empowerment.
The key thing about what you're saying is it's very important because at the end of the day, this is about saving a person's life.
Yes.
This is healthcare. Healthcare is a human right. And if these hurdles, these barriers can be overcome by better communication, just sitting down, having a WhatsApp group like you were saying, it speeds things up. You don't know how many lives you're saving. And you know, the person gets into the process is a bit clearer, and I'm absolutely in agreement that that's something that needs to be done. How does that get done? What's the next thing that we need to do to make sure this happens?
Of course, we have brought up in the budget meeting. We have told the minister and the top management do a cluster. Of course, I'll pursue. We will pursue to the government with the minister. I believe the minister has been quite receptive, and we work very closely with him. So we will tell him, why don't you do a simple thing like this? See, at the end of the day, right? Number one, you eliminate unnecessary processes.
Right.
Just like I told you earlier, right? What are the process? A patient journey. Before he sees a pakar. Right. You eliminate unnecessary process. Then you streamline the process. So I given you an option, right? Okay, streamline. Maybe pakar can do, a GP can communicate with the pakar. Streamline the process. Then you standardize the process. And finally, you automate. Automate the process. So you start to say you put digital first. You settle all these things, the workflows.
Right.
Then finally, when you do automation, it's much easier.
Right.
Automation is not going to work. See, no matter how high tech you are, you still need the high touch.
Right.
You solve the high touch problem first. Communications, relationship first. Then when the tools comes in, it becomes more seamless and smooth.
Absolutely. Very good point. Very good point. We're going to take a quick break. We'll come back here with more. I need to ask you about the consultation fees. We are not done with that yet. Back more with Dr. Arasu right here on Healthcare Simplified with Manvir Victor. See you in a bit. Hi, welcome back to Healthcare Simplified with Manvir Victor. In here, we have Dato Dr. Arasu, the current president of MMA, still talking to us. And so, sir, what we want to know is, the current budget came out. Is it better for healthcare? Is it better for GPs? Because, earlier we were talking about 11,000 of them. Earlier, 30% not doing so well. Another 30% just above, drowning. And, so 60% not doing well. Will the current consultation rate, which has increased, 19 years you guys have been fighting for this, it was 10 ringgit to 30, 35, and now has increased to 80 ringgit. Is that enough? Is that good enough?
Okay, first of all, I think to be fair to the government, to the Prime Minister and also our Health Minister, at least I have to commend them because this is the first time. This is the first time since the gazettement in 2006, the first time after many, many government. This is the first time they have the political will to actually to revise the fee. I think for that, I have to give credit to them. Especially to the Minister. When he was also PS 1.0, so he also deregulated the fees. But then, unfortunately, the government collapsed. They couldn't follow through the implementation. Of course, we had various negotiations with the ministry. So of course, finally, they are. What I see is that, of course, we were looking at least 50 ringgit as a floor.
As a floor.
As a floor.
Now the floor is back.
Now the floor is still at 10 ringgit.
10
So,
ringgit.
so I would say is that it's more political.
Okay.
Because if the government increased to 35 or 40 or 50, of course they'll be worried about public backlash.
Okay.
Okay. Then probably they thought public backlash is more dangerous than GP backlash. maybe they would have with the
The pros and
balancing,
cons, yeah.
pros and cons. They say never mind for the GPs, never mind. We appease them by giving the 80 ringgit. But I have to commend them
Right.
for doing this because nobody has done that in the past.
Yes. Nobody.
So to be fair to the minister, okay, to be too bad to minister, even though some are bashing whatever, to be fair to the minister, as the MMA president, I think at least he has honoured number one, the revision,
Right.
and at least he has given up to 80, at least for a start.
Okay.
After 19 years, at least for a start, we start there. Okay, the fear of the 10 ringgit is that the lower floor, because why 60% of the GPs, 60% of the patients seen in GPs, they're all corporate clients. That means they all come under employment health benefit.
Okay.
So majority of them under TPS, and they also have direct panels. That means there are SMEs where they deal directly.
Yeah.
And many of them
TPAs are third-party
administrators.
Yes,
so third-party administrators who manages employment health benefits of most corporate companies. It can be GLC, MNC, or big SMEs, 1,000+ workers, right? Even banks, bank institutions, and so on and so forth. So they do that. But of course, they get the mandate from the employers, how much to pay. They get a certain pool of fund, and then they have to manage it. Okay, so that's where the negotiation comes in. Of course, most TPS are also paying 35 ringgit or 1 or 2 40 ringgit, and the lowest is the moment the TPS is 20 ringgit.
The lowest is 20
lowest
ringgit. Okay.
Okay, so 2 of them paying 20 ringgit, 1 more 25 ringgit, and the rest are paying 35 ringgit. But remember this, these are all old rates, right?
Right.
So now we have to push to 50 ringgit. So when it comes at 10 ringgit, they'll be thinking, hey, the government is still telling 10 ringgit. That means I can even, I will maintain the current rate for maybe another for many, many years, right? So this is what we are fearful.
Yeah.
Okay, because why 60% of patients are dependent on corporate. And we have no choice. Because why in urban areas, most of the big companies, they just want to outsource these employment health benefits to third-party administrators and so on and so forth.
Okay.
So the employers also must understand. The employees also must understand if they really take care of their employees.
Yes.
What is happening to them? Can they get a treatment for 20 ringgit?
Right.
Now, can you give a consult 20 ringgit for that? And some of them big companies.
Yes.
MNCs.
Yeah.
MNCs, right? So will they do that if they operate in US? Will they do that if they operate in first world countries?
Yeah.
No, right? So are you doing that because you're operating in Malaysia? Do you think the Malaysians are not as important as people in your country?
Right.
So I think these are the areas we also have to put. That's why we're also telling the Ministry of Health, also get the Human Resource Ministry.
Right.
These companies, big companies must be educated. Hey, you're paying a medical services.
Sure.
You must pay certain amount, a decent amount.
Right.
Which is a fair amount because your people are, I mean, your employees are coming in.
Right.
Don't you think you have responsible towards your employees?
Yes.
So this is what I think we were worried about.
Okay.
Because why? The fee was regulated from 2006.
Yeah.
And because nothing was done, it was keep being suppressed and suppressed and suppressed.
Right.
So you can see a lot of commercialization taking place, right? So GPs are squeezed to the maximum.
Right.
So that is the fear that we have of the 10 ringgit.
Yeah.
So of course we are urging all the GPs that you have to increase your consultation fees.
Okay.
Okay, but of course we are also very mindful of our patients.
Sure.
Because it's very, very price elastic. You push a little bit because they have so many options.
Okay.
Because you have 10,000 plus clinics. As I told earlier, 60% of them are also struggling.
Right.
Right? So what will happen? So they said, hey, now I got so many clinics.
Yeah.
So when there are so many, people will try to undercut to survive.
Sure.
We cannot blame them because the system
Right.
made them to be like that.
Right.
Right. So this is where you need certain level of support
Okay.
from the government in terms of policy. We're not asking for money.
Sure.
The 10 to 85 ringgit, 80 ringgit, government is not paying a single cent.
Yeah.
So it's the first time, of course, they announced in the budget as well.
Okay.
So what we are urging the government now, at least get it gazetted ASAP.
Right.
And then the time-to-time revision, please remove the time-to-time revision. Probably during the regulation gazettement, please put there maybe every 3 years to be reviewed.
I would agree absolutely that 3 years is a very nice timeline because in 3 years, the price of fuel, the price of coffee, the price of your nasi lemak is going to go up exponentially, right? And whether it goes up 10%, 20%. And, you know, you guys were stuck with that gazettement for 19 years.
Yes, and then it becomes a political, right?
Yes.
So every even though the minister has the power under the regulation, but no ministers even in the past when they reviewed the specialist fee
Yes.
in 2013
Right.
during the Barisan time, also they went back to the cabinet. So it became political. So that's why what we are asking the government, at least since you never increase we appreciate for the 80 ringgit,
Right.
but of course we are disappointed with the 10 ringgit.
Right.
But of course, any negotiations you don't get everything right.
Yeah.
But at least to be fair to the GPs in the future,
Yeah.
so at least you put in the regulations every 3 years you must review.
So
So it's very clear.
I want to ask you, looking at the future and GPs and the role in society, because Malaysia has 95% access to GPs, primary care, how important are GPs in that? And how do we make sure that these GPs are now activated to helping healthcare? Because I currently feel that we still got sick care. We're not doing healthcare, right? Which means preventative screening, because it's available to me within 5 kilometers of where I am staying, 95% of the population. How do we activate them and how do we make sure that they are helped to survive, that 60% is not doing so well?
You see, for example, Manvir, if you look at the health, probably I'll share you later with the chart once I did I think you were there when we were together at the University Malaya.
Yes.
Remember the slide I presented?
Yeah.
So the healthcare, the cost goes up with the progression of the disease.
Yes.
1/3, let's say, pre-illness.
Right.
Pre-illness is where it's investment.
Yes.
That's where you invest. You make sure you got an active lifestyle.
Yeah.
You do all the preventive care, right? Then you fall into sickness.
Right.
You fall ill.
Yeah.
You have a disease.
Yeah.
So disease, then it progresses.
Right.
If you do not take care of the disease part, you progress into complication.
Sure.
So most of this budget, the 46.5 billion, it goes into managing so many of these things, right?
Yeah.
And the outcome is not very good because we're already in a complicated state.
Of course.
So what do? You invest into the pre-illness.
Yes.
That's where prevention comes in.
Yeah.
If you have disease, your job is that make sure you monitor very closely so that you maintain either at the disease or you become pre-illness again.
Yes.
So who can do that? The GPs.
Yes.
Because you have 10,000 plus GPs in the whole country.
Right.
Many of us are doing screening.
Yeah.
And then the government introduced SOXO screening in 2013.
Right.
Then PECA B40 came in 2018, screening for the B40 group.
Right.
And then government also gave a budget of scheme Perubatan Madani.
Right.
Okay. In 2023 was 100 million.
Yeah.
And 2024 was 2024 was 100 million. And 2025 it was 100 million. Then they reduced to 80 million.
Right.
For next year the budget they reduced to 50 million.
For preventive.
No, this is for scheme Perubatan Madani for acute illness.
Okay.
To the objectives to in 10 districts to decongest the government hospitals, right?
Right.
Now you have PECA B40. So we screen.
Yeah.
So what happened to the screening after screening? See, the important in patient journey is continuity of care.
Right.
Okay, I screen. What happened next?
Yeah.
So now the system is that I screen. Okay, kalau ada kencing manis. Okay, under KK you go to KK. You this one, you do this one.
Okay.
So the government, we have been talking to them.
Right.
So they must find a way, the funds, how to make sure it can be monitored at the GP clinics.
Right.
See, in terms of system, they already got a system. They already got a system through the Protect Health system.
Right.
They got Mais Jatra.
Right.
They're already empowering patients using Mais Jatra. The system's all there.
Yeah.
So they must have the mindset, seriousness, that certain funds must be allocated, how to rope these GPs in. See, this is their strength.
Yes.
In many countries, they're struggling without GPs.
Yeah.
Here you have abundance of GPs.
Right.
At low cost, right?
Yeah.
So pay them, make it affordable.
Yeah.
And make it affordable, activate them.
Yeah.
I think in the long run, we'll save a lot. And what about age population?
Yes.
Promote the GPs. Okay, if you can go and do mental health, the training in mental health, or if you can do aged care.
Yeah.
Okay, so that they can support the society.
Yeah.
You must start from now.
Right.
Don't wait in 10 or 20 years' time, then start thinking, what am I supposed to do?
Yeah.
We are always reactive.
Reactive,
They're not
yes.
proactive.
We are very poor
in
that sense. So where do you see, in your perfect world, in Malaysia, we've got abundance of these GPs, we've got a proper infrastructure. Low-hanging fruit, how would you as a doctor, as a businessman, as an entrepreneur, as a person who's traveled the world, how do you see us improving in 3 simple steps, in 3 things that we should be doing to move this?
I think number one, I think number one, what is needed is leadership.
Okay.
A leadership from the top level, that a clear direction. We already have the health white paper.
Okay.
The health white paper under the pillar of improving the service delivery, they've already spoken about enhancing primary care. It's
Okay.
already there.
Right.
The governance, financing model, it's all there.
Okay.
So what they need to do is that it's a 15 years plan, right? They must activate it. We know that some of it are in the Rancangan Malaysia ke-13. So this must be activated. At the same time, start doing pilots with the GPs for this NCD management.
Okay.
So they can do that. In terms of the certain infra, they already got, like I told you, Mice Jatra is there.
Right.
The system backup B40, I mean the Protect Health system is already there. So these are the things that they can roll it out first.
Okay.
Roll it out first.
Right.
Then you can monitor. You roll it out, you implement, you monitor, you fine tune, you revise, you just keep on improving.
Yeah.
You got to start somewhere.
Yeah, you got to start. There's no perfect system and then you
Yes.
start. Yeah.
And of course, to put all this together is
Yes.
digitalization.
Yes.
So the government said ASKM is going to give 660 million for internet connectivity.
Yeah.
Right. So take advantage of this.
Right.
Funding them. Then digitize the whole country with the GPs. They're doing that. They are working with the GPs also as well. So things are moving.
Okay.
So what we need, they must give a timeline. How many percent they want to do this? Okay, how do they move forward?
Okay.
So that there's attraction. Then in 2 years' time, there's election coming.
Okay.
Okay. So of course, see, the leadership changes, uncertainty comes in.
Right.
So many things comes in, right? So at least in the health white paper,
Right.
it's supposed to be future-proof.
Supposed to be.
Future-proof. So whichever government comes in,
Yeah.
they must carry out this because it was approved by participants in the parliament.
Okay. So if young people who are watching this right now, studying medicine and about to finish their medicine and become doctors, and they want to become GPs, what are the things that they should do to make sure that they're able to first sustain their business and then grow it over a period of time?
So I would say if those who are still in the government service, this may not be the right time to come out.
Okay.
Okay, so I would say that upskill yourself, learn as much as possible
Okay.
while in the government service. Of course, you can still come out. Then make sure you find a right location. You make sure that you find there's a place where there's a demand.
Right.
Okay, normally you must have a commercial, and then you must have industry. Residential is a very good combination of things.
Right.
So you can always go in and start.
Right.
So sometimes they like to open up in the places where there are so many clinics. So
Okay.
basically, eventually what happens, you actually dilute the whole thing.
Right. Right.
Dilute the whole thing. So of course, they can come out and do that.
Yeah.
So they must also learn about management.
Okay.
Things are not like that. Even nowadays, how do you maximize in your digital marketing?
Yeah.
Okay, important thing is your service.
Okay.
So we are not retail.
Yes.
We are professional services, right?
Yes.
So ultimately, what is the patient's expectation of you? Is service.
Mm-hmm.
So for you to have service, you must have knowledge.
Right.
Basic bedside manner.
Right.
All these are very important. You should be able to work hard.
Yeah.
You should be able to work. If you're going to open up only 14 hours, make sure you sit down and work. That's what I used to do those days.
Yeah.
We used to do 24 hours. For days, we used to work for 24 hours
Oh.
just
Wow.
to develop the practice.
Okay.
We are nobody, right? Nobody
Yeah.
knows us.
Yeah.
So we have, these are the sacrifices if they're willing to do. They cannot be thinking, I just do 9 to 5 and then every patient start looking for you. No, patients got so many choices now.
Right.
So how do you be the best?
Right.
How you want to be visible? So these are the things, sacrifices that you have to do. For me, it's not sacrifices. For me, it's investment.
Okay. Now, I mean, now at your age, and I'm not going to mention that age, but your experience, you started from Kulim, now you're here. You still work 14, 15 hours. You're hard to get, I know, all the time.
Yeah. I still see patients on a daily basis.
On a daily basis?
Yeah, on a daily. I still go to my clinic on a daily basis. I love to see my patients. I got a lot of patients.
Okay.
I see them. I go to clinic morning 7 o'clock.
Okay.
So I spend 3 hours, 4 hours a day, Monday
Right.
to Thursday, to see patients.
Right.
And I'm happy to see them. That's the most enjoyable part of my day.
That's probably your simplest part of your day.
Yes,
Because-
most simplest. No headache. I got no headache because why? That's what we were trained for.
Yes, yes.
And then I
absolutely.
love talking to my patients, and my patients love to see me.
Yeah.
So we really enjoy that. I really enjoy that. But the rest of it, of course, the most difficult part is managing people.
Yes.
That's the
Right.
toughest part, I would say, managing people. And of course, now as a MMA president, of course, the expectations are very high.
Yes.
They saw me being very vocal as a secretary general
Yeah.
for 5 years,
Yeah.
and they think that I can solve all problems. No, but definitely I'll push for certain things.
Okay.
So I told them the issues of the consultation fees,
Okay.
the TPA issues,
Right.
and the other one is the workforce.
What's the workforce issue?
Okay, workforce issue. We're talking about the government doctors.
Okay.
Government doctors. Right?
Right.
Even the private specialists are having a lot of issues.
Yes.
We can see the interference of the big insurance companies in terms of the management of the patients, right?
Yes,
So we
yes.
can see. I saw the YBCM issued a statement.
Yeah.
Okay, it's good. He has mentioned that there should be a task force formed to address all these things.
Right.
I think it's a high time.
Right.
A high time. And the other thing is that the government must also, you see, they have put it in such a way, healthcare is cheap.
Okay.
The government must change the narrative. Healthcare is not cheap.
It's not.
Our health is not cheap.
No.
We must make it affordable.
Okay.
Affordable.
Yeah.
You see, for example, are we going to pay our nurses low?
No.
Are we going to pay our doctors low?
No.
We cannot.
Yeah.
If you want talent to come in,
Yeah.
the work is not easy.
Yeah.
Okay, the work is not easy, right? So we have to appreciate that. We can see of course, we cannot match Singapore. But most of the time, people leave, whether you're in the private or public sector, is push factor.
Sure.
The problem is in-house.
The push
Not-
factor.
Yeah, it's always the push factor.
Yeah.
The pull factor, yes, there is, but
Yeah.
that's not the major one.
Right.
Who wants to go to another country,
Yes.
relocate the whole family?
Yeah.
You know the stress. You're not 5 years old relocating, you know.
Yeah. Yeah.
You're already 30, 40 years old relocating your family here,
Yeah.
a new place, you got to find new friends. It's a whole stressful thing.
Yeah.
Of course, many of them gone also, they're not happy after 50 plus, they come back, right?
Yeah.
So we have lost talent.
Right.
What are we going to do to keep the talent?
Okay.
So for me, talent is very, very important. That's a huge investment.
Sure.
Human capital is a huge investment.
Right.
So how do we keep them?
Right.
3 things only.
Yeah.
Pay scale,
Pay scale,
workload,
workload,
and the other one is career pathway.
career pathway.
Career pathway must be very clear.
Yeah.
The moment they enter housemanship, they must know, okay, if I want to become a surgeon, what is my pathway?
Right.
If I want to become a GP, what should I do? Okay, that means these are all smart people.
Yeah.
They're all smart people.
Yep.
So it must be crystal clear for them. That is the government's duty to make sure that in terms of policy, these are all crystallized.
Yeah.
Crystal clear. We must learn. Like just now you asked me, what are the things we can from other countries? I'm from Singapore.
Right.
How can they attract us? Forget about money.
Yeah.
One of it, when we spoke to some of the doctors, they're very clear of their career pathway. They
Yes,
know
yes,
exactly
yes.
what they want to become,
Yeah.
what they can do.
Yeah.
You see, so these are the things I think it must be done.
Right.
So ultimately, of course, for me, as I told earlier, the doctors can play an important role in leadership
Okay.
in healthcare,
Right.
but in collaboration with
Sure.
many. Today, you cannot work alone.
Right.
You have to collaborate with many parties.
Yeah.
Okay, why I'm telling doctor, not trying to be biased because we're closest to the patient.
Sure.
It's not to say we know everything. We also have to learn from everything. We have to learn a lot from a lot of people as well, but work as a collaborative.
Right.
Collaborative because we are close to the patient, we understand.
Right.
But of course, other things, finance and management, others
Sure,
can
sure.
come in. So these are the things that I will continue to advocate.
Sure.
Advocate, of course, I'll advocate about primary care,
Yeah.
the workforce, and digitalization. Digitalization is something that we should adopt.
There's one more thing I want you to advocate for. Bringing patients into this conversation, into this table. And the reason I'm saying that is because you said you are the closest to the patient. But the patient is also there in that room. But the patient is not at the table when discussing healthcare, financing, all these things, which unfortunately, it happens in Singapore, it happens in Thailand, it happens in other countries. I'm part of that there. But as patients, we're not
Let's do it.
and this is
Yeah.
the important thing
Yes.
because patients are not just sick people. They are doctors themselves. They are lawyers, they are engineers, they are astronauts, they can be anything. And so they put a different lens on how they want to see their care taken in those pathways, which sometimes I find, like you said, the patient pathway is not clear. The
Yeah.
doctor pathway is also not clear.
We
Something
don't
needs to be
communicate
checked.
each other.
Yes.
So you rightly say, Manvir, I think what we should do is that I totally agree with you. We should bring the stakeholders,
Yep.
those affected as a
Yeah.
patient. Of course, many of us maybe already a patient.
Yeah.
Okay, already a patient, right? So it's no harm getting the patient group to come in,
Yep.
make them understand what's happening. And we have to listen.
Yes.
And we have to tell them why, this cannot be done.
Yeah.
Why this one we can do. Or maybe this one makes sense.
Yeah.
Sometimes they may give the best simple ideas,
Yes.
which it has no cost to the government.
Right.
That can be implemented.
Yeah.
I think this kind of course, we have the Malaysian, Malaysia's health safety,
Patient safety.
patient
Council.
safety day.
Yeah, council.
So,
Yeah.
council, and
Yeah.
we have annually we have one day we spoke about that. We only speak one day, then forget about the
That's
rest of the
it.
day.
Yeah.
So 365 days, only one day we speak
Yeah.
about it. Then we paint the color,
Yeah,
change
yeah.
the color and everything gone, right?
And,
So I
and-
think
and this year for World Patient Safety Day, they had that discussion. There were no patients there. For the very first time, there were no patients there. I was aghast at the fact that there was no patients there. I was like, really? We didn't even get invited.
mm,
So anyway, I digress. Thank you so much for sitting down here and sharing so much of your knowledge and your aspiration from MMA. And please accept that we, Vital Signs, will be here to help you any step that you take, because we want to make sure that this information is available for everyone to see, that they need to understand how important primary care is in the long game of providing health care, not sick care, health care for the nation. Thank you. So, any final words from you? I mean,
My final word is simple: health is everyone's responsibility.
Very good. Thank you so much.
Thank you. Thank you,
Dr.
thank you for the
Arasu.
opportunity.
So that's it for us right here on Healthcare Simplified with Manvir Victor. If you need to find out more information, hit that subscribe button. Do communicate back with us and let us know about this and how you felt about this particular episode. See you again next week. Bye.